This is Stirrups, candid conversations in women's health, the podcast where we answer your burning questions and discuss the evolution of women's health through every stage of life. Join Dr. Randolph Scott and duly certified women's health nurse practitioner and certified nurse midwife, Kerry Autry, as they discuss the unique health concerns women face and share expert advice to assist you on your journey to maintaining your health and wellness. If you're looking for informative discussions, tips from qualified professionals, and a community dedicated to women's well-being, then you're in the right place.
All right, welcome back. This is Stirrups, your candid conversation in women's health. We got the dream team back, and so I'll let you introduce yourself as you did with our last one, Katie.
Thank you, Dr. Scott. I'm Katie. I'm a physician assistant here at Carolina Elite. Happy to be here.
And I'm Kerry. I'm the midwife sidekick. I kind of like that.
Yeah.
I'm going to describe myself. So I am at Carolina Elite, of course, with everybody else here. And we are thrilled to be talking about GYN procedures today.
Yes.
A little bit scary, really, really important, and something that we do here all the time. So I think we wanted to take a little bit of time to kind of break them down, at least certainly the ones that we do all the time. Dr. Scott.
Yeah, I think this is a opportunity to really discuss the office procedures that we do. Of course, there's plenty of procedures that are done throughout the hospital and things of that nature, but we're going to focus really mainly from the office side of things. Now, we've already had a podcast with respect to IUDs, and so certainly you guys can take a listen to those. But today, we're really going to focus on three particular procedures that we do in the office. There's some variation to each one. The first one is that sometimes we come to a point where we've tried every medication that we can for abnormal bleeding, and it's just not working. And when you have said, all right, enough is enough, sometimes an ablation, which is a procedure where you kind of burn down the house a little bit. And so to that extent, it sounds scary, but really from a procedural standpoint, it's a very, very, very safe procedure that is done in the office setting. And matter of fact, you don't really burn the uterus in its entirety. It's really just the lining of the uterus. So it's a slight burning process that takes place to get you to your desired goal. We're also going to talk about when the pap smear becomes abnormal and you've diagnosed that abnormality, there is treatment available. So we have a lot of patients when they have an abnormal pap smear, they think, what, Kerry? That
that this is it.
This is it.
I know,
yeah.
But I mean, that's true of everything in GYN, right?
Well, that is true.
Every time something is wrong, they're like, this is it, hysterectomy. But there is a lot of spaces between abnormal test results, abnormal bleeding, and hysterectomy. And I kind of love that Dr. Scott is talking about this because these are procedures done in the office. So it's your familiar, gynecological home. You come in, you see the same people that you always see. You see Dr. Scott who walked you through that diagnostic procedure, and now he's going to help go ahead and treat so that you can get back to your life without the hospital stay.
That's right. That's we talked about in one of our previous episodes about the pap smear and just your overall preventative examination and evaluations. That's where some of these things become very valuable to patients because it can prevent you for something that down the line is a much more difficult and more challenging situation. And so when you get that abnormal pap smear, it doesn't necessarily mean, all right, we're just going to rip out this uterus or you just have cancer.
No.
Some patients are really fearful of that. And we're very cognizant of that. Sometimes there's a family history that is guiding some of these decisions. And sometimes it's very anxiety provoking. And so we want to try to meet you before that ever becomes a situation where it is harmful to your health. And so the next thing that we'll talk about as well in this particular segment is the hysteroscopy. Now, the hysteroscopy in a lot of ways can be both. We talked about that diagnostic situation. We're trying to figure something out. Taking a look inside the uterus, what's going on and what's happening, but it can also be therapeutic. It can sometimes satisfy issues and concerns that you have related to abnormal bleeding. It can be very helpful in that. And sometimes, for some patients, it can be helpful too in terms of managing fertility concerns too as well. And so
I always tell my patients, and like Katie, you can speak to this too. I think we need to rename everything in GYN women's health because everything sounds terrifying. But what we're doing today is we're going to kind of talk through each of these to make them sound less awful and let you know how they really could play a role in your health and how we can make it much, much more approachable.
Man, that just kind of warms my heart, makes me chuckle at the same time. I think we should put on our website different names or alternative names for some of these procedures.
Do you remember we tried this? We brand them.
Yeah, we brand them as a uterine look-see.
Yeah, that's all we're doing.
Can we patent that?
I'm here for a look-see. That's all. We're just taking an extra look.
We tried this once before, Dr. Scott, and some of the suggestions were not great.
Okay. Okay, all right. We may have to back it up a little bit.
Yeah.
All right, so let's talk about the uterine ablation to be more specific. And so, Kerry, what are some of the things that are done prior to the ablation for bleeding concerns for some patients?
And we had a great podcast about this too. But usually when people are coming in and they're asking questions, and like we said with that other visit, if you're going through pads and you are really suffering with your period, if you've ever even thought, I wonder if I'm bleeding too much, you need to be in here asking us because you very well probably are.
Yeah.
Mm-hmm.
So we usually try a bunch of things in the office first, right, Katie? Because Katie and I are not surgeons, so we don't have these things to fall back on. So we have to land where we live.
Yep. And it's usually in an annual when someone tells me that they soak through a pad in 2 hours,
right?
And then they have to wear a diaper to bed. I'm like, no, that's not normal.
I know. It's amazing what people come to live with and think of as normal. Yeah.
Chronically anemic.
I had one patient who said, well, I just go through an entire box of tampons every period. That's normal, right? And I'm like, no.
And expensive.
So.
Goodness gracious.
Yeah. So where do we start? We start with some other things, right, Katie?
That's correct.
Yep.
So now we're trying to provide a permanence to things, really get you to a point where you get your life back, where all of these things have been just so insanely, managed in a way that you're trying to kind of get through, but it's just not working for you anymore. And you kind of are figuring out some more permanent situations. And so the ablative technique is usually done in the office setting. We're getting really, really great at modifying the ablative therapy. Some patients require anesthesia or sleep in order to get the procedure done. But now there are actually some techniques where the possibility of actually going to sleep is not as necessary. And so the ablative technique for you is something that can get you to the point where you may never have another cycle again. And so that's what I relay to patients, that we can make it all go away as a possibility, but it's not necessarily a guarantee. But for a lot of patients, it's about 90% effective. Either A, I'm going to stop that period and it's not coming back, or B, we'll get you to the point where your bleeding is drastically reduced. And so to that extent, I think that's a great way as an intermediate for patients before you're considering more major surgery that can have you out for several weeks, as opposed to the ablation that may have you out for a few days. And so it works well in terms of lifestyle and all those great things. The risk is relatively small. Katie, is it good for every patient?
No, it's not a perfect fit for everybody. Right. And that's why we use it when it is the right fit. But when it's not, we've got some other techniques.
That's right. Mm-hmm. Sometimes, from a ablative standpoint, you have to be able to insert an instrument inside the uterus. So if there's a roadblock, for example, like a fibroid that's in the way, the ablation is not going to work well. Or may not work at all to that extent. So sometimes your diagnostic and your evaluation prior to can help you make a decision about that. And so the ablative technique, great tool for the right patient. Post-ablation, after it's done, a lot of patients think, okay, I have it done, and all of a sudden my bleeding concerns are gone immediately. That's not necessarily the case, because For most ablative therapies, it's going to actually take a few weeks in order for it to get you to the point where your situation is optimized. And so from a procedural standpoint, just know that, I get some patients, they'll call me, several days after the procedure, say, I'm still bleeding. Well, that's okay. That's okay. Yeah. That's okay. That's part of the process. And hopefully we can get you to a point where there's more satisfaction a few weeks later.
Dr. Scott, can you just break down for us exactly what it is? Because I want to be really clear that this is nothing like a hysterectomy. Nope. Everything stays where it is. You will still have a uterus. You will still have ovaries. You will still have hormones. You will still have a vagina. You will still have a vagina. You may very likely, you may even still have like monthly symptoms, even if you don't have any bleeding.
Okay, I'm sorry, my mind goes all over the place. But no, this is true. You can think you're gonna burn your vagina too. I don't know, but yeah. So.
Even with a hysterectomy,
Right. This is true. And so, to your point, Kerry, you're right. What is it that happens? The response in your recovery is based upon the limitations of the technique, meaning that there's no cutting that's involved. So, we're not cutting somebody's uterus in order to achieve a goal here.
Nobody's going to leave here with stitches or anything like that.
Right. There is no stitching that's required at all. And for most techniques, there are various techniques that you can use. You can use a freezing process. You can actually use hot water to do things. But the way that I typically do the ablative part is through actually high frequency ultrasound, which creates heat. And that heat is what is going to be the permanence for patients. And it doesn't take long.
Right.
From an ablative standpoint, we're talking about really minutes, as opposed to a hysterectomy is hours. And so patients are finding that because it's a short-term situation in terms of the procedure itself, you have a short-term recovery.
And it just basically creates scar tissue.
It does.
Inside the uterus, so that all those blood vessels that used to help build up that lining are not able to do that anymore because that scar tissue is in the way. So that's why the bleeding is so diminished.
Yeah, and that's important to note because we'll have some patients that think, I'm supposed to have a cycle, but I'm not really having a cycle.
Right.
Nope. Is that we've kind of cauterized those blood vessels and the scar tissue has sealed it. And so that therefore there's no more bleeding. It's almost like a cut on your skin that heals in a very similar manner where you're left with a white scarred area. Very similar appearance takes place inside the uterus.
Mm-hmm. So, I think we've kind of really delved into why we might want to do this. They've come to see us. We've tried all the things, the birth control, the IUDs, all the things, and we just can't get the bleeding under control. And it's become such a quality of life issue at this point.
Yep.
So now they're going to go see Dr. Scott for their ablation.
Yep.
What should they do to prepare for that? How do they need to, what are expectations on day of procedure?
Yeah. And so every patient will have a diagnostic evaluation. And once that's completed, you've made that decision. Now the time has come where you're getting ready to have the particular procedure that we're recommending for you. The biggest thing for you is that just know that from a procedural standpoint, generally things are relatively smooth when they are done. Sometimes you do go to sleep, sometimes you don't. Sometimes there's an anesthesia team that will greet you. But day of the procedure, it's almost like coming in for your normal evaluation into the office. There's some exceptions to that. For example, we want to make sure that you're usually fasting, that there's
especially
nothing.
If there's anesthesia,
that there's nothing on your stomach at the time, because I don't want you to bring something up at the time of the procedure itself. And sometimes there's a vagal response that you can have, which kind of hampers procedural aspects. So limiting food intake is one of the biggest ones. Outside of that, patients sometimes ask, do I need to wear certain garments? And so usually we recommend free flowing, just so that it can make things relatively easy. because oftentimes it's not like it's a major surgery where you're, disrobing and all that other good stuff. And so it's something that's relatively smooth, but something free flowing, just so that the mobility is easy even after you leave. The biggest one for us is trying to anticipate the needs of the patient after the procedure. So the procedural aspect of things, again, it's like having your normal office procedure, which you may or may not go to sleep, but the biggest factor is not necessarily eating, but it's the post-procedure. Now, post-procedure wise for us, the recovery usually is pretty good. For most patients, they'll have it on a Friday, okay? And by Monday or Tuesday, they're back to work. That's a very reasonable expectation.
Good, because I keep selling it that way for you. I'm like, I hope he's living up to these expectations.
I'm in trouble. Short terms.
But no, truly, that is a realistic expectation, which is one of the reasons that we love this procedure before we go to a hysterectomy.
The second one is that you can have the expectation that there's going to be some pain. Okay, so pain-wise, for most patients, are tolerated with just the pain medication that's over the counter. But usually I go a step further. I will prescribe stronger pain medication. And if you need it, great. If you don't need it, that's fine too. But it's just being proactive about any pain needs that you would have. And then the other factor is we talked about the bleeding circumstance. Sometimes there's ongoing bleeding afterwards, and you're thinking, okay, he just sold me some snake oil. I said it was going to work.
When's this thing going to work?
Right. And so sometimes that's several weeks in the process in terms of that. So.
Well, I was going to say, and I know that Dr. Scott is not alone in this, but anytime you're going to have a procedure like this in the office, you're going to have a visit with the provider who will actually do the procedure before you come in that day. So everything, all of these things will be laid out during that appointment too. So you're not left wondering. And then of course, we are always available, and I'm sure that's true for anybody else doing these types of procedures as well. So if you've got questions afterwards, we always bring people back in.
Yep.
Fantastic. All right. Next procedure in line for us, the LEAP procedure. And so this one's a pretty big one in the sense that this is part of the reason, Kerry, right, that you come in for your annual exam. And so Katie, from a LEAP procedure, let's back it up in terms of the LEAP procedure itself. Who is a good candidate, and so what usually transpires before the LEAP procedure actually happens?
Yeah, so usually we've done a pap smear or two, or maybe a couple, and this is years later, and we're saying, looking at our algorithm, let's maybe be on the safe side. This is looking like the right thing for you.
Yeah, and so it usually starts with the pap smear. Again, that preventive examination. The pap smear helps set the agenda. And then you may transition from the pap smear to a colposcopy that may require a biopsy. Once you actually are considering the LEAP procedure, you're getting to the point where, all right, we're dealing with something a little more serious. As a matter of fact, usually for a LEAP procedure, the concern is so much that there's the possibility of development of cancer. And so we want to do this so that you never, ever get to that situation.
We never get there.
That's right. And so with that, it doesn't mean, again, that you do have cancer. I want to stress that very, very much so. But it means that, hey, there's a concern there and the possibility exists, so we need to intervene on your behalf. And so the LEAP procedure is quite simple. For most of our patients, they don't need to go to sleep. Now, it's not a walk in the park, but at the same time, doesn't necessarily require the anesthesia to make you to go to sleep. Now, it doesn't mean we don't give anesthesia, okay? Don't want to be clear about that. We do give anesthesia, but it's localized, and usually that local anesthetic is enough to get you through that LEAP procedure. Now,
well, most importantly, especially when you're talking about it being uncomfortable, it's very quick.
Yeah, it's a very, very rapid procedure, and usually should only take your provider a few minutes at the very most. Usually it's more like seconds to kind of get things done and get you to a fair amount of sampling. We say it so commonly, LEAP procedure.
Yeah.
LEAP.
What's that stand for, Dr. Scott? I mean, it sounds cool, but what is that? Are we leaping?
Yeah. So, is it leap of faith?
Feels like it.
No.
Yeah.
So, but it stands for loop electrosurgical excisional procedure. So we just, catchphrase it and simplify it as a LEAP procedure. So it really is technical, but as a procedural standpoint, I find it highly effective. It is both diagnostic. It can tell you how bad the problem was. So the biopsy that you have prior to the LEAP procedure is a good sampling. It told you that something was wrong. It's telling you that, hey, potentially there's an issue. But when you have a bigger tissue sample, it tells you really the depth of the issue and the situation for you. And so for the LEAP procedure, I like it in that sense. And it also is curative. More than 90% of the time you have this done, you never have to have it done ever again, assuming your situation didn't change. So effectiveness and then office time is relatively small. Now, recovery-wise, that's a factor that's worth discussing. Most of our patients will leave out of here, particularly those that don't need anesthesia, without too much of an issue or concern. There's not anything that you necessarily need to do, but you will have some discharge, and that discharge really is a major factor for you in terms of, just kind of making sure your hygiene is okay, because that can exist for several weeks on end for you in terms of the discharge that you have. And so it's not uncommon in that regard for us.
And we usually recommend that you don't put anything in the vagina after a LEAP procedure. So no tampons, even with that discharge. Just don't put anything inside the vagina. No sex for a couple weeks usually.
Yeah.
Should we be cleaning or?
Oh, I mean, I do.
I set you up there.
You said the cringe.
When we talk about a pet peeve.
Oh, yes.
Kerry,
another pet peeve.
Pet peeve douching.
Never.
I hate it.
Ever.
Please no.
Never.
It's a self-clean machine.
It's amazing.
I mean, it's amazing.
It's amazing.
It was engineered that way.
Exactly.
It's itself. Yeah. I mean, what could be more cool? Please don't put soap in there. Please don't. We're begging you.
All right, back to the lead. But yes, certainly, Kerry, yes, you don't need a whole lot there. Just kind of allow things to heal naturally, but certainly avoid inserting anything at all until your doctor kind of gives you the thumbs up where things are going for you.
I think that brings us to our last procedure.
That's right.
For today.
This is the last one, at least for the topic of discussion for us, is the hysteroscopy, okay? Hysteroscopy is a tool where essentially it's a look inside the uterus. We talk about that look-see. The look-see.
Would you say?
Yeah, the look-see. So the uterus is such a dynamic organ, and sometimes you're trying to figure out exactly what's happening because there's a particular concern. Perhaps maybe you saw something on ultrasound, and you're trying to say, hey, is there something here that could be contributing to the problem that I can actually take care of for you? And so when you do the hysteroscopy, you go in, you take a look, and you're looking at the internal aspect of the uterus, the contours, the shapes. You're looking at really the tubal openings for you. And sometimes we find things that are like uterine polyps. And polyps are small growths of tissue that you can actually remove and help remedy some of the concerns that you have. Sometimes there are fibroids, and fibroids can be also internal as well as external. And sometimes you can actually remove those fibroids from an external standpoint. Sometimes our patients are dealing sometimes with concerns of fertility, and the inside of the uterus can be off, and the contours and the shape of it can be a little bit irregular. That may perhaps contribute to things. And so it's a very helpful tool to look at inside, and certainly where, the aspect of pregnancy takes place, and it lets us know perhaps is really a very important detail in terms of what's going on with some of the challenges that you may have. And so with that, the utility of it is great. It's a relatively simple procedure. Most of our patients do very well with the aspect of the hysteroscopy. Oftentimes, we don't find anything at all.
But that's comforting.
But that's
I mean,
okay,
it can be curative. As you said, you can find things that can be managed during that same procedure. But sometimes it's really just part of a diagnostic process where we're trying to understand maybe why you have bleeding and we haven't been able to make it stop, or why you've been having trouble getting pregnant or staying pregnant.
Yeah. And to that extent, for patients with bleeding concerns, if you do the D&C part to the hysteroscopy, so we say D&C hysteroscopy, the D part stands for dilation and the C part stands for curettage. Curettage is just kind of a fancy way to say sampling. That means we're going to take a sample from the lining of the uterus. And so it can be helpful even if you're having bleeding concerns, but in a way that's not necessarily a permanent, like the ablation that we were talking about. Your lining regenerates, it restarts, and it's no hindrance to your ability to conceive or anything else like that. Right. So it works out in that way too as well. So hysteroscopy, maybe with some additional things, can be very helpful. So the hysteroscopy, again, is the look part. Sometimes I'm removing polyps, which is, again, called a polypectomy. Sometimes we're taking sample, and so you add the D&C part to things.
Stand by my comment. We need to rename everything.
I know, polypectomy. I mean, a lot of praise.
But the hysteroscopy itself, of the things that we've talked about today, Dr. Scott, I think this is the one that is the least uncomfortable for patients, and tends to be one of those things that it's going to be 15 minutes that will be uncomfortable, but you can probably go about your day.
Yeah. This one, if you're doing the hysteroscopy, the expectation should be that there shouldn't be a whole lot to your recovery.
Right.
But sometimes it can be. Every
depending on if
a
procedure was combined with a hysteroscopy.
Yeah, absolutely. Especially if you're adding the D&C part to things.
Right, if you're adding another procedure, of course.
Yeah, it can be a little bit different. The biggest expectation that you should have from hysteroscopy is that in order for me to be able to look inside the uterus, or any provider for that matter, is oftentimes you have to put water inside. And so you can have a watery light discharge.
Right.
Now, as technology is advancing and moving forward, a lot of providers are now doing hysteroscopy without the water aspect. So you may not have any water discharge depending on how it's actually done, but your provider would certainly explain that to you prior to. Some patients will have anesthesia, some patients will not. And again, it depends on the technique and things that you use in order to get things done for you.
So I think I was going to say, I just want to make sure that we're being really clear that we have talked about several procedures all together with the hysteroscopy. The hysteroscopy itself is really just a special way of looking inside the uterus.
That's correct.
The hysteroscopy refers to a special type of imaging.
That's correct.
And that imaging can be combined with procedures like removing polyps or the D&C that you talked about. But those are really two separate things.
That's right.
I think when we talk about hysteroscopy, it's like a guided tour of the inside of the uterus. It gets us better pictures than a plain old ultrasound would, even a vaginal ultrasound. So
that's right.
Hysteroscopy on its own is really part of the diagnostic process, but can be combined with procedures that are curative.
That's right. And it's not like it's two separate procedures.
No, they're done at the same time.
Times,
right. Yeah.
At different times.
Right.
You're doing them all together. So your provider will have really a game plan about everything that's going on. So
before that day. Yeah.
Before that day. That's exactly right. So for example, if there's polyps, so you'll have a hysteroscopy with polyp removal all at the same time. Let's say you're dealing with infertility concerns and you think there might be something called a uterine septum. You may do the hysteroscopy, identify the septum, and then actually do a septum where, you will actually go in and remove the septum that's present.
Right.
So it's all done at the same time, but certainly it's considered to be different procedures.
Well, and especially when you're having it with somebody like Dr. Scott, who's been doing this for so many years, you're usually going into that hysteroscopy with an idea of what you're looking for. You know, we saw something on ultrasound that looks like it could be a polyp, and you've got this bleeding. So you're going to be counseled before you come in there that day that we're going to do the hysteroscopy to be sure that's what's going on. But we think this is what we're going to find, and we're going to plan to do this at the same time. So you're really set up for that. But
so that's all in the plans there. And so with that kind of includes some of the office procedures, not everything we do, but the main ones that we get a lot of questions about. And so we're going to end this segment here for us. Thank you for joining us on Stirrups. Anything that we didn't cover, ladies?
No? I don't think so.
No. Okay.
No. Yeah.
All right. You guys know how to find us. Thank you.
I feel like we missed our dad joke, though.
Unfortunately, we did not start off with our dad joke, okay? So we're going to conclude with our dad joke.
I just want to say the dad joke about gynecological procedures was a little tough, but I think you nailed it.
Yeah.
Okay. All right. So it gets better, right? And so, all right, ladies, why did the uterus get a camera crew?
I don't know, Dr.
I don't
Scott.
know.
Because it wanted to make an intrauterine documentary. All right. There we go. That's pretty good. Okay. I got more, but we're gonna conclude with that.
Stop it there.
We're gonna start.
Go all day.
All right, ladies. Thank you.
Thank you for joining us on this episode of Stirrups. Be sure to send us your women's health questions and topics you'd like to cover by visiting our website, CarolinaEliteWomen.com. If you enjoyed today's episode, please subscribe to the podcast and spread the word by sharing it. To find out more information about Carolina Elite Women's Care, visit CarolinaEliteWomen.com. Stay healthy and stay empowered. We'll talk to you soon on Stirrups.